whenever you start contouring, whenever I start contouring, probably you are also doing the same. First, I see the entire slices. From above, below, I just see once. I scroll the slices and I see the slices first and then assess what is there. So we can identify few muscles like the latissimus dorsi muscles, the pectoralis major and minor muscle, and the intercostal muscles. 2 or 3 vessels also you can identify. But the technique I am showing you, first you identify the upper extent. In this is the chest wall, no? So, okay, I'll show you the first the chest wall and then the breast. So as you can see, they have put marker laterally, medially, and on the scar. For chest wall, you try to cover the scar. But here, as you can see, the scar is going, just crossing the midline. So usually it doesn't, but as it is crossing the midline, so we'll try to include the scar also. So what I was telling is, you put the 2 bars in the, this is the lateral markings they have put according to the clinical marking, the lateral extent of the breast, and the medial marking also, I think they have put here, this one. This one. So what I do is, I take a measuring scale. This is the technique Dr. Munshi has taught me. I put it like this. So this is the area which will be the dose capsule if we put one tangent from medially and another tangent from laterally. So whatever is there in between, I will contour from above down. For chest wall, it is quite easy. So I take a big brush, and in the chest wall, we contour the intercostal muscles also. We take it inside. So, okay. So need to decide the first. Probably this is the appropriate one. So you draw it in the slice, in the middle slice, as you can see in the coronal section, or you go to a topo view and you can see in the middle section. I have drawn. Then I will go up. This is the upper border marking they have made. I will draw one contour here. This is the caudal marker they have put. So I will draw up to this, because I believe that they have put the marker according to their clinical judgment that this is the caudal extent of the breast, and they have gone, I think, 2 centimeters below the caudal extent of the opposite breast. So as you can see, I have drawn in few slices. Now I will interpolate it, and now what I will do is I will crop this from the body. In the chest wall, I don't crop it for 0.5 millimeter. For breast, I do it. For chest wall, only 0.2 millimeter I crop. Then as you can see, a nice contour has been generated so easily. After generating this, you might have to do a little bit of editing here and there. In some slices, it may have gone outside the capsule, and in some slices, you may have to draw the area which are missing. So if you do that, it's nicely and very easily, a nice chest wall contour has been drawn. So this is very easy doing that. After doing that, you just check whether in midline you are crossing or not. So in this case, as the scar is going across the midline, I will increase here manually a little bit. I will try to cover the scar. In few slices, because the scar is going across the midline. So it looks a little weird if we go do like this, but as the scar is going to the opposite direction, I am just increasing the slices here a little bit, just to include the scar. Okay, this much I think okay. Again I will crop it. A little bit of editing I need to do. That's it. Usually, if the scar doesn't go across the midline, no need to do this. You will get a very nice, clean contour. So I'll show one chest wall. So, chest wall at breast. This is a chest wall. Chest wall and cavity I will show. Chest wall also similarly you can do. Go to the middle slice. Just draw a line from the lateral to the medial contour. Here I will, according to your clinical judgment, you can go a little lower and a little anterior. So I will draw a new structure. So breast is a bit, it's not that easy like chest wall. Breast is a bit difficult because you need to do a lot more editing in breast. So you draw it like this and don't include the muscles in whole breast. But if you see the seroma or the cleaves below the muscles, then you need to, I always include that. If the surgical cleaves are there, sometimes it happens. Here they have put the caudal marking, but we will not go above the the caudal part of the sternoclavicular joint. This is the sternoclavicular joint, so we will go up to this, we will not go above that. Even if it seems that the breast is extending above that, we will not go. According to the guideline, I will draw some contours. Exclude the chest wall muscles. This is the caudal extent. We are coming to the caudal extent. This is the last slice. Now you interpolate and then you edit it from the body. Give a 0.5 millimeter. Okay, it's not that nice, contour has not become so nice because in some slices I have drawn a little more and some slices a little less. That's why. I have not followed this line actually properly. So you need to do a bit editing in these cases and then you will get a, am I doing something wrong? I will draw it again. So this is the lateral, this is the medial entry point. I start drawing from here. Then I go above. go above. But I will not go more than this because this is the sternoclavicular joint. This is the last slice. Now I think it will be fine. Then I'll, because I can't remove it 5 millimeter because in some areas it is very thin. That's why it is looking like this. Why it is happening? Going from this area. এটা কি হচ্ছে বলুন তো? CTV high, extended outside body. Okay. That is why it is happening. Oh, structure. I'm doing something else and naming it. Oh, that's it. This is a different structure actually. This is the structure. That's why I was thinking what's happening. So that's a different structure actually. I was editing. I draw something else and I was editing something else. So that's how you get it. And in breast you can actually modify some areas. In breast it is not always like the chest wall, it's so easy, but if you want you can modify some areas. As you can see that if you put a medial tangent from here and a lateral tangent from here, the entire area will be inside the dose envelope. So that's how we actually contour the breast. Now the second part is the cavity. So there is a score called cavity visualization score. So you have to put some markers inside the cavity. Here they have put markers, clips inside the cavity. You can easily see the clips. Very nicely they have kept the clips. We don't have, we have a control region, we'll name it cavity. So if you want, you can draw the clips separately or you can draw the area also, as you can see. So they have put the clips here, but clips are quite close together. Okay, and the anatomical deformity also, whatever you are seeing, you need to contour. Seroma, if any, you have to contour also. So as you can see some anatomical deformities and the clips. And here is the scar. Scar also they have marked. So there is a question in case if you can't see the cavity or if there is no clips, what do you do? So you draw the cavity and now you have to give a 2 centimeter margin to the cavity for making a CTV boost. So I have seen many people, they are very strict, they draw only very small cavity according to the pathological size. Yeah. No, it's a cavity, sorry. Cavity. Give 2 centimeter. Yeah. Now you edit it. Editing is very easy. Okay, CTV boost to edit whichever is going outside your CTV. Okay, you get the cavity. So if you can't see the cavity, in some cases, you may not be able to see the cavity. What do you do in that case? First of all, before chemotherapy, before surgery, the patient should be examined by the radiation oncologist before starting anything. And you need to clinically mark in which quadrant the tumor was. Or whoever has examined need to draw a diagram and mark it, yes, in this quadrant the tumor was there. In that case, you need to treat the entire quadrant if you can't see the cavity properly. Rather than missing the cavity or missing the boost area, you treat a little more, nothing happens. So if you don't see the cavity, you treat the entire quadrant. If it is in outer quadrant, upper inner quadrant, central quadrant, or lower quadrant, wherever it was, you treat the entire quadrant. So that is how you contour. Okay. Now, if there is any question, we can answer. And then Dr. Ramakrishna will teach how to draw the lymph nodal structures.
Thank you, Dr. Shayanpal. It's a nice contouring session going on. So I have a question regarding the chest wall contouring at first. So in chest wall, I have seen that the medial contour goes to the almost opposite side of the breast, and the central heart distance is centimeters. So in that case, of the heart.
Hello. What I have drawn is whatever to always do a DIBH technique. Okay. So, but most of us, we can't do it because of the facilities available or because of some other issues. But if possible, you should do a DIBH. But if you can't do a DIBH and in the left side, and if you have taken a scan and you see the heart is really near to the chest wall, it is really difficult. So you can't modify your contour to spare the heart. In that case, heart dose will be high. So better, if possible, you do a DIBH technique in left-sided breast or chest wall. And we usually don't go up to the opposite side. I have shown it just to show you if we use two tangents, so how to contour so that the contour remains inside the dose envelope. So if you want to modify, then you can modify it also. But whenever they put the beam, even if you modify the upper portion, suppose in this slice, if I modify it, like here also, as you can see, a little bit of portion has gone to the opposite side, right? So suppose it looks very nice if I modify it here, okay? I will not go across the midline. I can do it, okay? Even, or I can put it here in the midline, or I can do it. But the issue is, whenever they put the medial tangent, they'll put the beam like this. So this area will invariably get the dose. Even if you remove it from here, so they'll put the tangent like this, so that they can't put the tangent like this, then they will miss this area. So they'll put the tangent like this, and invariably this area will get the dose. So to be accurate on your contouring, or just to keep it not to cross the midline, you can edit it. And eventually after the planning, if you see the plan, this area will get some dose if you put tangents. Similarly, in lateral also, you can draw it like this. It looks very nice if you draw it like this. But in that case, they have to put the beam like this, and eventually the dose will look like this.
Okay. So I got it. Regarding the breast contouring, I can see there is a wear mark in the breast base. So should we contour apart from this? That means there is a fiducial marker in the base of the breast. So why we become the lateral border? It's into the anterior part of the latissimus dorsi, and also in the midline, where the medial border. We have to contour only the breast base.
Yes, so in the guidelines also in RTOG, if you read, it was there. Many people follow that the anterior border of latissimus dorsi should be the lateral edge of the contour. But in RTOG also they have mentioned that you have to clinically judge where actually the breast ends laterally. So they have put the marker here. So I assume that the marker has been put after clinically assessing that this is the lateral border of the breast or the opposite breast.
Okay.
A little lower, probably it is not in the mid axillary line. It is in the posterior axillary line.
Okay, regarding the boost cavity, so there is a 2 centimeter margin apart from the cavity. So if we want to give treatment with the electron, we have to have the additional 1 centimeter. It will almost half of the breast treatment will get the boost treatment. So what?
Electron treatment, electron planning is a bit different. In electron planning, usually we don't do contouring and we don't plan it in the TPS. What we do is we assess the size of the tumor, whatever there in the pathological specimen, and then we need to add 2 centimeter around it. And in the area where the scar is there, we just put our beam and make it flat. I mean, make it facing it directly, and then we assess the distance, what thickness we need to treat, and we prescribe the beam. For electron, you have to give 2 centimeter margin, otherwise there will be inbowing of the isodose curves. So in electron, if you want to treat with electron, the field size invariably will be a little bigger than the photons because of the nature of the electron isodose curve.
So in that case, can we reduce the boost margin?
No, in electron planning, actually if you draw the boost cavity, that will only guide you where you are giving your electron beam. Because in electron, you can't plan it in TPS, right? You directly put the beam. Even if you put the beam, you need to put the beam directly and opening a little bigger film. And you just calculate, because the TPS system is not well developed for electron. Okay, the algorithm that we use for photon is not developed for electron. That's why if you put a beam here and see here, it is actually a very primitive dose calculation algorithm that you use in TPS.
Okay.
I have a question that in previous case, chest wall case, we covered the extreme end of the scar. Is it always necessary to cover the extreme end of the scar if it crosses the midline? Because if we cover whole the scar, we can see the heart dose and lung dose will be increased. So it is mandatory to take hold the scar within a target volume.
Yes, so there is there is a little bit of variation in the opinion whether you need to chase the scar or not. If the scar, as per the UK guidelines, they say if the scar is inside your volume, it's okay. Please don't go and chase the scar. If it is going outside your treatment volume, so you don't need to chase the scar. Here I have shown because it has gone outside. Sometimes even it will go a little outside, maybe a few millimeter outside your volume. In that case, probably I will be comfortable to taking the scar also inside my volume if my dose constants permit.
Okay, thank you. I have another question that in case of breast contouring, what should be our upper limit, the sternoclavicular junction, or we should clinically correlate the opposite breast or second intercostal rib? What should we follow?
In the guideline, they have said that you need to correlate with the clinically with the upper margin of the breast, but should not go beyond the sternoclavicular junction. Maximally up to the sternoclavicular junction. That is the maximum limit.
Thank you so much.
Thank you for your very nice contouring. Actually, I don't have this idea that how easily breast contouring can be done. So thanks a lot. My question is to you. Sometimes due to the variable chest wall shape, sometimes the opposite breast gets some dose. So what is the dose constraint of the opposite breast?
See, the opposite breast actually should get as low as possible.
Is
So
there
if
any
you
mention like
see the opposite base, whatever we are concerned about, opposite base is actually the stochastic effect. Like if the breast gets some amount of dose, also there is a risk of having a second cancer, having malignancy in
yes,
that breast.
yes.
So you should try to minimize it as much as possible. So when if you increase the dose, I mean the scope, the chance increases. But even if the breast gets a little bit of dose, also there is a risk.
Yeah.
But if you use tangents, that's also another point of using tangents. Only with tangents you can reduce the dose to the opposite breast. If you
Yeah.
use any other configuration, the opposite breast dose will be more.
Yeah, in the first contouring, when we actually crossed the midline and followed the
Yes, the
scar mark,
scar.
that in that case, actually, the opposite breast actually gets
Yes.
some
In my
dose.
clinical practice, probably I will not do it. I will not
Yeah.
chase the scar. I just showed you because in some cases the scar might go a little outside the contour. In that case, you might have to include that.
Yeah, I can
But in
understand.
clinical practice, I will not go. If it is going to the opposite side, I will not chase the scar.
Yeah, so in our country, actually, maximum patient comes from the periphery and they have a very big scar mark. That's why actually I wanted to ask that question: is it mandatory to follow the
Yes,
scar or
in
not? That
that case,
actually Dr. Auditri also asked
yeah.
you.
In
Yeah.
that case, I don't think you should go and just really chase the scar and I mean increase the dose to the opposite breast or the heart.
Okay, thank you. Thank you so much.
So there is a practice like in case of if the scar crosses the midline, so there is a practice that after doing the chest wall irradiation to give the electron radiation to that scar. What is your opinion regarding this?
Yes, so people used to do it, used to give some boost to the scar also, to put a bolus to the scar to increase the dose to the scar. But over the time, the consensus opinion is actually this is probably not needed. So when I was doing my residency, I saw people putting a bolus on the scar to increase the dose on the scar. And many people have debated that should we boost the area, should we give a little more dose to the scar. But probably this is clinically not as important as we thought previously.
So far, this may we go with this contouring, and if the lung doses is not meet the wear requirement, so will you consider for modifying the volume, or you will let go with the lung volume?
So again, actually, if you use tangents and if your lung distance is okay, so the mean lung dose or the lung dose, the constant V20 or V30 or V5, whatever constants you follow, the opposite lung actually gets almost no dose if you use tangents. So one side lung is completely saved. And only with tangents you can achieve the lung constants. The low volume lung constants you will achieve with tangents, the V5 volume mainly. If you use any other configuration, the V5 dose of lung will increase. So yes, in some contours, in some anatomies, when there is the structure is a bit different and a lot of lung comes inside, it is a challenge of doing it. So now we have we can use intensity modulation and some higher techniques in these scenarios to reduce the lung dose, because we need to assess the movement, how much it can go posteriorly and anteriorly. Probably some posterior lung dose we can actually reduce by creating a dummy structure in that area and give it a constant. Use tangents, medial lateral tangents, 1, 2, 3, whatever you want to use, and then you draw a dummy structure in that area, and then you ask the physicist to give some constant to that area to decrease the dose to the lung, the area which can be safely saved.
And you have the skin you have drawn, it is a zero from the zero margin, right? So I found it is difficult. Our faces struggle to. Yeah.
No, actually, I wanted to give 0.5 millimeter margin to the skin, but because there was another contour drawn, I was just withdrawing the other contour and I'm not getting them. No, no, no. I give around 3 to 4 millimeter or 3 to 5 millimeter inside the skin. For chest wall, it is most of the times not possible because it is so thin.
Thank you. I have a question regarding the internal memory delineation. So you can, so do you separately draw it or just dig down the contour?
Yeah, so Dr. Ramakrishna will show you how to draw the nodal volumes. But all the nodal volumes I prefer to draw separately. And Dr. Ramakrishna will show you how to draw it.
Okay, thank you.
Now I request Dr. Ramakrishna.
So any further question? Otherwise, we can proceed for the regional nodal irradiation by Dr. Ramakrishna.
Good evening, everyone. Myself, Dr. Ramakrishna, I'm a senior radiation oncologist at Yashoda Hospital, Secunderabad, India. Basically, I would like to discuss certain things regarding the breast contouring, nodal contouring. This is a teamwork. So nobody can do, like a radiation oncologist or a surgeon or a medical oncologist or a pathologist, including a radiologist. So all should involve in doing all the things. Like a surgeon saw the patient with a BCS or an MRM, or he is doing a lymph nodal dissection or a sentinel lymph nodal biopsy, we don't know it. And you should have a good work like paperwork. Where is the lesion? Is it an upper quadrant or a lower quadrant, inner or outer? Everybody should be on the paper. If possible, somebody is undergoing a BCS. So it is the role of a surgical oncologist to keep the clips there for further treatment. So nobody, as a single person, it's very difficult to do all the things. Like, fine. And so many people are practicing the axillary lymph nodal, sentinodal biopsy. Most of the times, no. Right? So these are all the matters when treating a patient with the radiation. So because the last patient will come to us after completing the surgery, after completing the chemotherapy, he'll come to us. The patient is vexed up with all the treatments, right? So it is our duty as a radiation oncologist to explain everything and coordinate with the surgical oncologist and to coordinate with the medical oncologist, and we have to see the before surgery, whatever are the investigations like MRI or a CT or a PET, we have to take all the things, then only you have to plan all these things. As my friend Sayan Pal explained very nicely, but coming to the nodal delineation, it's very, very difficult as a live practice like this, because it takes a long time, right? I have the pictures with me, I'll show you. So what to be included, what to be excluded is the important, like axillary dissection, or a supraclavicular, or internal memory lymph nodes, where you have to start, where you have to end, when you have to include, when you have to exclude. That is the major things, fine? This is a brief introduction. And the second most common cause of death from the cancers in the world. And radiation therapy plays a very important role in the management of breast cancers in terms of treating the chest wall or a breast or lymph nodal drainage, and is highly effective in treating as a palliative modality too. So treatment overview. So we can decide it in such a way that early breast cancers, locally advanced or metastatic setups. So early breast cancers include T1 or T2 lesions or N0 or N1. The surgeries can be BCS or an MRM, the later followed by chemotherapy, radiation and hormone treatments. It depends on the stage. And the locally advanced breast cancers are like neoadjuvant chemo followed by surgery, and the radiation and chemotherapy will play a huge role here. And in the metastatic settings as a palliative treatment. This is a brief nodal anatomy. As you can see, the regional lymph nodal drainage to the breast is the axilla, supraclavicular and internal memory lymph nodes. So what makes it? We can divide the breast in 4 quadrants: upper, lower, inner and outer. There are 4 quadrants. So in treating, in giving a radiation to the internal memory lymph nodes, in giving a radiation to the, depends on the site of the lesion, like upper and inner quadrant are lower or inner quadrants, we used to include the internal memory nodes too. I'll explain in further slides. So then how to delineate the axillary lymph nodes or internal memory or a supraclavicular lymph nodes? Generally, axillary lymph nodes can be divided in as a 3 levels, level 1, 2, 3. Here is the lateral to the pectoralis major levels will be considered as a level 1, and medial to the medial border of pectoralis major considered as a level 3. In between these two, the two heads of the lateral pectoralis minor vessels will consider as a level 2 lymph nodes. I'll show you the photographs too. And the nodes in the intercostal spaces along the edge of the sternum will consider as the internal memory lymph nodes for the first 4 intercostal spaces. Supraclavicular lymph nodes will be in the supraclavicular fossa. These are all briefly the internal memory lymph nodes 1, 2, 3, 4 supraclavicular area, and this picture shows the level 1, 2, 3 axillary lymph nodal drainage. And what are the indications when we have to include the axilla, when we have to include the supraclavicular regions or internal memory regions? So generally in indication of RT, axilla and supraclavicular area is included in, these are all the conditions. Supraclavicular lymph nodes positive with no dissection. 1 to 2 lymph nodes can be considered as a negative lymph nodes in treating supraclavicular area. Or inadequate axillary dissection. What I have explained earlier, it depends on the surgical oncologist for going for a sentinel lymph nodal biopsy, or some people don't address the axilla at all. And high risk with no dissection. The high risk includes, there are 4 to 5 conditions. One is the age of the patient, whether she is a premenopausal or a postmenopausal, or any perineural invasion or a lymphovascular invasions, and the tumor size should be more than 4 centimeters. These are all the high risk conditions. And axillary lymph node positive with extensive extracapillary extension, we have to include the axilla too. And in a post BCS or an MRM with 4 or more node positive, we include the axilla and supraclavicular. So these are all in a different fashion of supraclavicular and internal memory regions, what I have explained. The central and medial lesions with high risk and the positive supraclavicular lymph nodes in IMN chain and positive supraclavicular lymph node in axilla with the drainage to IMN and scintigraphy, we have to include the internal memory area too. So in evaluation of the nodal management, earlier people used to do has many changes over the last decade. For years, axillary lymph nodal dissection upfront was the standard of treatment, which increases the morbidity in future. After radiation, people will develop the lymphedema. So in the later introduction of the sentinodal lymph nodal biopsy has been reduced the lymphedema chances and as a staging procedure and avoiding high morbidity too. The recent randomized trial showed the survival benefit for patients receiving regional lymph nodal irradiation. And there are certain studies people will follow all over the world with MA20 or EORTC included the supraclavicular and IMN, indicating that inclusion of these nodes should be considered irrespective of the nodal status. And Amaros indicates RT can be used in place of lymph nodal dissection, axillary lymph nodal dissection itself. And Z11 reported good outcomes of node positive patients undergoing BCT with whole breast radiation, which includes some level 1 to 2 lymph nodes but not supraclavicular. All these things are not following in our countries as like in India. What we are following is the RTOG guidelines, as my friend Paul explained, and where we have to start, where you have to end for the axilla or supraclavicular or internal memory. The guidelines what we are following is the RTOG guidelines. I'll explain in a brief. So suppose if you are including the supraclavicular lymph nodal place, then where we have to start? The cranial border, where you have to start. So actually I don't have a cursor to show. These are all the things. No, I have this one. So this is the supraclavicular area where we have to start. This is one to exclude the thyroid medially, which is very important, and anterior aspect of the scalene muscles posteriorly, it is showing very clearly, and the posterior edge of the SCM laterally, and anterior edge of the SCM anteriorly, caudal edge of the cricoid cartilage caudally. So these are all the things where we have to include. This is the first slide where you have to start with the supraclavicular lymph nodal radiation. And comes to the caudal border. So it is at the junction of the first rib clavicle, what is showing the arrow, and the caudal edge of the clavicular head. So this is the last slide. In the overall, this is the, I'll show you the overall also, where you have to mark the supraclavicular, internal and axillary. And this is the internal memory lymph nodal drainage, as I have told, the first 1, 2, 3, 4 intercostal spaces. So this is the first slide, the cranial border of the internal memory node to be included at the superior aspect of the medial first rib. This is the first slide. And the caudal border, which includes the cranial aspect of the fourth rib. So that picture is showing the cranial starting point, and this is the ending point of the supraclavicular lymph nodal chain. The earlier also, and this picture shows the total supraclavicular lymph nodal drainage area, the last picture. Then comes to the axillary place. This is a little bit clumsy. So generally we don't practice the level 1, level 2, level 3 of axilla. So we'll plan total axilla, but for being an explanation, I've started with axillary lymph nodal station 1. The borders are cranial border, where you have to take is anterior surface of the pectoralis major and the lateral dorsi anteriorly. This is the cranial aspect. And the medial part, we have to take medial border of the latissimus dorsi muscle laterally. And this is the end, mean to say subscapularis muscle posteriorly anterior surface. And the axillary vessels cross the lateral edge of the pectoralis minor muscle. This is the medial border where you have to take. And this is the cranial border. Comes to the caudal border. This is the border where pectoralis minor insert into the rib, clinically at the base of the anterior axillary line. So this is the caudal. This is for the level 1. As such, with the level 2, this comes as a level 1. This picture shows the level 1. The level 2 is the cranial border, all the borders are written there. The lateral border of the pectoralis minor. So this includes the level 1, and the above includes the level 2. And the caudal one shows the ribs and intercostal muscles posteriorly. And in the medial border we have axillary vessels at the pectoralis minor muscle. And anterior surface of pectoralis minor anteriorly we have to take the upper border. This is the caudal border for the level 2 lymph nodes. And as such with the level 3 also. So this is the level 3 where we have to take the medial border of minor muscle, and these are all the constraints, medially, laterally, upper and down. But the thing is, cranial and caudal is very important. The overall, this is the caudal border. The overall how it comes is the level 1, 2, 3. This is the thing. But in a planning we don't make as a level 1, 2, 3. We'll make it as an axilla completely. For just to sake of completion, I'm just explaining the level 1, 2, 3. Fine. And these are all the things. How we'll plan it here. 1, 2, 3, we'll make it as a combined, only one station. So generally, after making all the things like whether to include axilla, whether to include the supraclavicular, whether to include the internal memory, so after contouring, so the overall, what is the overview of the technique of radiation, what we are giving? Everybody knows it's a position like a supine, hands above the head tilted to the opposite side, right? And what we will do, the immobilization, simulation, and the target volumes and treatment planning. The single isocenter technique what we are using right now is with the two tangential fields with the parallel fields borders using wedges and field in the field segments forwarded IMRT. The center where I am working, we have all the techniques like we can treat with the two tangentials, or it is like a forwarded IMRT or IMRT or a rapid arc. So we have all the techniques with us so that we can minimize the dose to the lungs, and if it is on the left side we can minimize dose to the heart, and even we can minimize dose to the, when you are treating a supraclavicular area, the thyroid is very important for us. Fine. In every aspect we will consider, including the opposite breast. Fine. And dose and fractionation what you are recommended. In the morning session there was a good discussion saying that whether we can go with the 50 gray in 25 fractions and an earlier concept. Now the concept has been changed to the 40 gray in 15 fractions, and it's came now 5 fractions. When you are including the axilla, a supraclavicular or an internal memory area, you can't treat the patient with 5 fractions with a high dose. We have to go with the 15 fractions only. It is a negative N0 only we can treat with a 5 fractions. The dose what we are recommending in our hospital is it's 42.5 gray in 15 fractions. And what are the goals of treatment? To ensure 100% PTV is covered by 95% of the prescription dose. In other words, underdose to any part of PTV shall not exceed 5% of prescribed dose. The rules what we are following, right? And tools of plan evaluation is isodose color wash and color DVH. I'll show you. This is the thing, right? So what we have shown is the 50% where the blue line is indicating towards the lungs. But what we are planning is the 90% is the supraclavicular and axilla is delivering. And CTV, PTV has to be covered with the doses in the range of 95 to 105%. To the 40 gray plan, what we are planning is the 40 gray right now, fine. Therefore, hospitals define for the doses more than 105% for the 40 gray is recommended and should be in the PTV area. And the doses at the organs of risk. So generally what we are seeing is the lung and heart most of the times opposite breast spinal cord. So in the plan, 100% what we are doing is excluding the thyroid. Most of the times thyroid is excluded. The lung dose should be less than 20% of the lung receives 20 gray or 17 gray in 40 gray this thing. And heart mean dose is less than 26 gray and volume receiving 20 gray is less than 10% in 50 gray plan and less than 17 gray in 40 gray plan. What we are planning, opposite breast is not exceeded 2 to 3 gray at all. The spinal cord max dose, you know very well, it's less than 45. This is the DVH what we are using. So we'll make the organs at risk and PTV and we'll calculate the dose volume histograms. This is the plan evaluation. We'll calculate in each and every organs at risk, then only we'll plan. What I've explained in the earlier slide. So we'll consider here and we'll execute the plan. In a conclusion, ultimately our aim is to understand how best we could improve our quality of radiotherapy by ensuring the consistency in target volume contouring, given our advancing ability in precise delivery techniques. This is a precise delivery techniques with a least side effects, with a least morbidity and good quality of life to the patients. No evidence to suggest that using either the ASTRO or RTOG delineating guidelines were superior in regards to the greater consistency of delineating the breast or nodal target volumes. The people who are following the RTOG is major part like in India or Bangladesh, people will follow the RTOG guidelines. Need not compare with the ASTROs at all. It all depends on the decision of the treating physician. Fine. So ultimately what I can tell is when to include the nodes, whether it's a supraclavicular, axillary or internal memory, depends on the site, depends on the lesions, whether it is a T1, T2 or a T3 lesions, whether it is a BCS, whether it can be a MRM. So depends on the clinician opinion and the surgical oncologist, and even the before surgery what we are considering is an MRI breast or a PET CT breast. All the things will matter in treating the axillary or a supraclavicular internally lymph nodal areas. Fine. So any questions?
Yes, thank you, Dr. Ramakrishna sir. It's a nice discussion and presentation. So I have a question regarding the axillary nodal irradiation. If a patient having one positive lymph nodes and there is adequate lymph nodes dissection was done, at least 10. So after that, should we consider for axillary nodal irradiation in this patient?
It's a sentinel lymph nodal biopsy or a dissection.
Sentinel node was positive at that time, one, and oncoplastic surgeon was proceed to axillary nodal dissection, but after adequate dissection there is no positive. Only one node was positive.
So he has removed the 2 nodes and 2 nodes are positive.
Among 2, 1 positive, so she was planned to do the axillary nodal dissection.
No.
And adequate dissection was done.
No, we don't treat the axilla in that case scenarios, because adequate lymph nodal dissection includes at least they have to remove
level 2
12 lymph nodes. In among the 12 lymph nodes, at least 4 lymph nodes should be positive in treating the axilla. Because already axillary dissection has been done. If you include the axilla, the chances of getting the lymphedema is very high.
I have a reverse scenario. A patient came from abroad and she was having 4 lymph node positive and total 47 lymph node was removed in that case. So,
The chances of lymphedema is more.
so
The axilla should not address 47 lymph nodes at all.
we are facing this kind of
He
problems.
has removed axillary lymph nodes.
Axillary lymph nodes total 47.
Is it completely axilla has been removed? I think. Huh?
Yes, yes.
Even in the rectum cases, nobody removed so many lymph nodes. Is it not?
Thank you, sir, for your very nice discussion.
Yeah.
Actually, regarding the axillary coverage, if we contour following the RTOG guideline, if we want to cover whole of the axilla according to the contour, according to RTOG, during planning, do you use only the anterior beam or do you use any posterior beam to cover whole of the axilla? This is my first question.
Okay. Good one. Only one question or any other things?
Okay.
One, right. So that is a practice earlier. When we are treating the patients with a two-dimensional RT, the two tangential everything. Right now, what we are planning most of the times in our centers is what we are planning with an IMRT. It's a minimum, right? But long back, we used to treat the posterior axillary field too, but not nowadays. It's a completely what you are treating the chest wall with an IMRT. Chest wall plus axilla plus supraclavicular.
Okay, sir. I have another question.
Yes.
We are in COVID situation, so many of our patients become exposed to COVID and develop lung fibrosis or various kind of lung problems. So what constraint, if a patient is already affected in COVID and has lung fibrosis, so what lung constraint you follow? Is it always V20-20 or for hypofractionation V20-17? What do you follow?
This is the first time I'm coming across this type of question. Because in a COVID condition, somebody has developed a lung fibrosis. In which part? Second thing is, in which place? Like right, left, or in which area what we are treating. But when you considering the malignancy versus the COVID, it is the malignancy is important, right? So we have to strictly follow the rules. If you consider anything is lung to be spared, if you miss the chest wall or a breast, you have a chances of recurrence.
Thank you.